Innovation in AI have a reputation for being rapid. Everything moved so fast, especially when it comes to technology transformation. Doing this well takes a lot of time, and you have to proceed with caution and intent.
Welcome back to Ground Truth, an open conversation on technology reshaping our world. If you're new to the series, in AI, Ground Truth is the real world data you check model against, the actual answer, not the model's guess. In community health, the ground truth is what's happening at the doorstep, in a household with a health worker providing care. And that's the spirit of the series, measuring the big claims against that reality. Our first conversation was with Rafik Rikorian of Mozilla and looked at AI from the top down. Ownership, open source, the big questions. Today, I'm very excited to go all the way down to the ground. I'm Andra, I'm Co-Executive Director at Medic, and I'm delighted to be here with Abbas Wandella, a Senior Digital Systems and Data Specialist at D3. D3 is a digital health organization expanding access to high-quality, essential healthcare in sub-Saharan Africa, and it enables better decision-making at every stage of a person's health journey. In Zanzibar, D3 built and supports Jamii Afya, which is the national digitally enabled community health program built on the Community Health Toolkit, the open source tools Medic Stewards. Now they are carefully adding AI to that work, starting with an assistant for community health supervisors. And I'm excited to dig a bit more into that work today with Abbas. Abbas is an implementer, an expert in this context, and we are very excited to have this conversation with him today. Welcome, Abbas. So maybe before we talk about any technology, take us to the ground. When you picture the person of all this is really for, a community health worker or a supervisor in Zanzibar, who are you seeing? Walk me through a piece of their day.
Thank you so much. This is a great place to start because it's where D3 always starts by putting people at the center. Here I'm seeing Hamida, who is a community health worker supervisor at one of the health center in North Bay district in Zanzibar. She's one of the people we spend the most of the time during the designing of this AI solution. Hamida, despite being community health worker supervisor, she's also a healthcare worker and supporting the community health workers across her catchment areas. Hamida sits down with the community health workers once per month for the supervision. And by then, she supervised 5 to 15 community health workers. Hamida expected to have reviewed the data in Jamii Afya platform and to know what health challenges her community facing over time. So the monthly meeting session with the community health worker, she takes that time to discuss and see different challenges that persist in that particular catchment area. It's also where CHW brings their questions, the numbers they're not so sure about during the health service delivery in their catchment area, and the situation that they don't have obvious answers. Hamida is expected to answer them during this monthly meeting session at the end of the month. She told us she used to read hard the question. Sometimes she stretched supporting a lot of people with limited training and even less time to prepare for that particular meeting with their CHW over time. Even with this rich digital data following into Jamii Afya application, she was often working in the dark, seeing high-level counts, not a clear signal of what was actually changing in our community. When a community health worker asked something she didn't have detail on, she'd later have to say, I'll get back to you tomorrow or in the next session with them, and then chase that answer down herself before she could close that particular loop. So the person I see is someone carrying a lot of responsibility with more data than ever, but not enough support to make sense out of.
Lovely. Thank you so much for taking us to Amida's day and bringing a bit of visibility in the important work people like her are doing every day to support their communities. You wrote something that became kind of North Star for this series that we are doing now, which is that designing technology and especially AI responsibly starts with human realities, the workflows people navigate, the decisions they make, the constraint they face. And this is what you share a bit about Hamida. So let's start exactly there, diving a bit into your AI work. You did some research with Dalberg recently that revealed something very surprising, that again, supervisors aren't short on data. They're drowning in data. But can you walk us through what that looks like in practice? Why does the supervisor's month actually involve all the reporting, the reconciling, the phone calls to confirm numbers, or anything else that's part of their monthly routine?
Here's what a supervisor month looked like before. Even with a full digital platform in Jamii Afya, supervisors were not short on data. They were drawn in it. In practice, they were still learning on facility registry, which are paper-based reports alongside the other legacy registries that are found at the health facilities, alongside the Jamii Afya, and none of it added up to a clear picture of what actually changing, where, and why. To get that picture for a single monthly meeting, a supervisor would move between these different data collection tools and also include the data that were found in Jamii Afya dashboard. So those registered and paper records and phone call to the community health workers, trying to piece it together by hand, actually consume their time and involve a lot of complex process to put them together, which a gradual rise in malaria cases, for example, or a drop in postnatal visit in one village could easily get missed until it became serious. So supervisors told us this routine took more than 2 hours to prepare for a single meeting with the CHW over time. And then even after that, the meeting could still feel generic because CHW walking away with feedback that wasn't real tailored to what happened in the community in that particular month that they were reporting. So the problem we chose wasn't supervisor need AI. It was a person in spending 2+ hours a month fighting her own data before she can even do her job. Because remember, these supervisors, they also have to attend other routine job in their health facilities. And then the CHW she supervises are getting generic guidance as a result. That's a problem worth solving with or without AI. AI was the tool we wanted to test against it, not to make clinical decision, but to do the heavy lifting, summarizing patterns across these different tools and different reporting that were produced over time, while leaving judgment and action in human hands.
I love that you mentioned the judgment being at the human level, as this is something that I think resonates a lot in everything you do at D3. I have more questions around that a bit later, but I'm curious to know when you sit with the supervisors and community health workers, what do they actually ask you for? You mentioned that it takes a lot of time for them to put together the reporting and prepare the different meetings, but I would like to know, what do they tell you? Is that very different from what technologists assume they want?
Yeah, so beyond the technology, these community health worker supervisors, they need to have insights from the data that they are collecting. So that was something that was missing. And despite the rich data that were collected over time, having an insight that could inform the decision making across these catchment areas that they're supervising over time, it was difficult for them. And then from that angle, it was a pain point on how like they're having a lot of data in their hand, but they cannot make insight from the data that they were collected over time. So what they speak and what they tell us is they cannot make informed decisions based on the data that they're collecting over time. And they cannot have those insights that could support them in day-to-day activities based on the work that they're doing. So it's more of the workload on preparing this data, more of shortage of tools that could support them to have inside information or inside data that they could use to do the decision making with their CHW, but also in their day-to-day activity that could inform the health service delivery across their district.
And I believe that's what your supervision assistant was designed to do, right? It's guiding, not deciding for supervisors and helping them navigate insights from their end of month data. I think you also mentioned that the tool is explicitly not the decision maker, and I love that clarity. You know that there's also a body of research on human in the loop systems tend to defer to a confident machine even when it contradicts their own judgment, for example. And sometimes the system might look transparent and the more people will trust it. So, for example, Hamida is exhausted at the month end and she has this data that she has to navigate. What actually keeps the guide, not the side, from becoming that decides and the human just signs off? Like, what are her options to judging if the insights she's receiving are in line with what maybe she was expecting to see?
The insight that she is receiving basically is generated from the monthly data that have been reported by the community health workers through the Jamii Afya platform. So over time, this solution generates the monthly end trends for Hamida or for the community health supervisor. And then through that monthly health trend, it provides with a specific area that experience a certain case or burning point whereby she needs to put her attention during the monthly meeting session with the CHW. So the trust comes after this data, they are generated from the trusted platform of Jamii Afya. And then through the AI solution, it creates the monthly trends and guide her like through this area you have to go or you have to take into consideration during your monthly meeting session with the community health workers. So the trust persists from the data that are collected by the trusted community health worker through the Jamii Afya platform. And then from there, the monthly health trend that are auto-generated from this AI solution from Jamii Afya facilitated her to guide this meeting and to guide this supervision session with the community health workers. These guidelines are approved by Ministry of Health based on a certain cases or a certain service in the community or in the health service delivery. So the trust exists since the source of data that collected are reliable and the system that is used to collect this data is a national scaled system of Jamii Afya.
This is an important thing that you are insisting on, the trust, because we live in a world where AI current models can generate code, insights, decisions in seconds and minutes. But you did mention the trust that was built through the years and through this strong engagement with the Ministry of Health, with the communities, with the people being served by the program, and how that is crucial for actually the success of any AI intervention or solution. So it's not just about having the strongest model, but basically building on data quality and relations and trust on the ground to make that successful. If we zoom out a bit for a moment, medic stewards, the CHT, you are one of our core community members and champions. You adapted the CHT, made it the backbone of this entire community's health system. And a tool that's becoming national infrastructure is rare. It's not easy. as it might seem. What does it genuinely take to go from just an app to something a government owns, runs at national scale that people trust, and the people trust the data that comes from it? What's the part that outsiders most maybe underestimate?
I would say letting go of your own idea of success is letting go of ego. So the Community Health Toolkit is a platform that Medic steward, and it's what that has built the Jamii Afya platform here in Zanzibar. So we started with 3 modules back in the day, small deliberate scoped based on the RCH and nutrition and ECD way back then. So we thought our transition plans were more of handover documents. By the design, the description of the future in, I would say, in an own image. The moment you write down how government should run a system you build, you've already decided your way of running the program in the only right way. So as the government stepped into ownership of this program, it started to change the program, and it grew beyond the 3 modules that were there before. So the 3 modules expanded to 14, new scaled model. And alongside that, the community cadre also shifted from community health volunteers to community health workers. Since the prioritized also moved, the workflow also evolved, and the new direction said that didn't match the early build of the platform. So by ownership, we say is a power of relationship. And that defines the future of genuine power is that you don't need anyone permission to change things. We had to let go and change how we support the partner with the government. And today the program has grown from those original 3 modules I've just mentioned to 14 new modules. CHW have gone from volunteer to formal government cadre, and it's one of the flagship program run by Ministry of Health here in Zanzibar. So none of that growth would have been possible if we would build something closed and rigid. The CHT is an open source, and it is designed to fit the community health context rather than force the context to fit in it. So when the government prioritized shifted, the platform could actually accommodate that. We could scale with additional community models as the program grew, instead of the system becoming ceiling on what the ministry could do. And it matters as much that we weren't starting from zero, because Jamii Afya is already existed in an ecosystem in Zanzibar. So it wasn't a new system that jumped in, but we built in from what already existed rather than replacing it. It is a big part of why the transition held together, even the program change shaped around this transition period.
This is amazing. I'm constantly inspired by the work you've been doing through the years at D3. And I also love how you and in general your team have always talked about the work. I think this honesty and approaching with such a humble take, it's foundational to the success of all the impact you've achieved. Maybe going back to the Dalberg research, I think you surfaced maybe 7 possible use cases as you were looking into where it would make most sense to apply AI to better support the community health. I love that you only moved forward with one. This is like a discipline that is very rare in AI right now when people are just trying everything at once. Another area that came into that research, besides the supervisor support and helping them with insights on the data, was the language and good local data that also came up as a make or break. Like at the moment, the supervisor system is fully in Kiswahili. It's on WhatsApp where people already work. We know that many languages are out there are not maybe trained in local languages that people actually speak and use in their day-to-day. Why do you think language is so central to trust on the ground? And what do you think that it's still missing to make this work everywhere you need it to at the moment?
Kiswahili is a language most of supervisors and community health workers speak here in Zanzibar, but in the context of the AI solution that we designed, not only it operates in Kiswahili language, but also it operates in English language. Kiswahili is a language they use CHW with their family, with their health system around them. So this wasn't real design decision on our side. The supervisor told us clearly they wanted it in Kiswahili. And our job was to listen and make that possible and make that happen. So as I've just mentioned, the tool is also available in both language, Kiswahili and English language, but Kiswahili was preferred and is what makes it feel like theirs. And we had to translate into Zanzibar local context Kiswahili, a pure version of Kiswahili language. So what's still missing, I would say right now is voice functionality to the AI solution, which limit them to provide response or to provide queries based on the voice input. So right now it is based on WhatsApp and in Swahili and both English. But not every supervisor is equally comfortable typing, and voice is often how like people actually communicated day to day. So adding voice functionality is one of the things we have flagged for the next phase and not something we have got solved yet. And alongside that, offline resilient also is the other thing that we know we still need to strengthen before this goes further to other geographical regions.
You definitely highlighted one of the pain points that we've heard in many other countries where health programs that we work closely with. The voice to text is definitely a gap at the moment, especially when we talk about local languages. And to your point, the fact that most of the community health workers, they are offline for most of their month doesn't help. It doesn't make it possible to use existing, maybe off-the-shelf models that need an online connection to function. I think the future small models running on the devices that are actually adapted to the day-to-day of the health workers will be crucial in supporting them provide better care and actually make use of like AI functionality as much as possible. So I'm really excited that you're looking into this. Definitely exciting work there. Knowing what you know now, and you're a board builder and a member of the community. How do you wish the funders, the technologists, the ministries understood about doing AI for community health well?
Innovation in AI have a reputation for being rapid. Everything moved so fast, especially when it comes to technology transformation. That hasn't been true for us. Doing this well takes a lot of time, and you have to proceed with caution and intent. First, I would say use open standards. That's what gives you adaptability, and it's what makes it possible for government to scale a tool or a solution. Compare when you build something onto that don't use open standard. The CHT is a good example of that one. And I would say something different to each group because each one has different approach on how to go with this. For the funders, back long-term system strengthening, not isolated pilots, and fund the learning partnership that connect this evidence to scale, not just to demo and just leave it like that. And for the policymakers, I would say they should create room for digital innovation, but govern it with integrity and equity and local ownership from the start to the end. And for the technologists, I would say design for the actual condition of the frontline work from day one, understanding their pain point, understanding their need, put them at the center of the designing process. Basic device, low bandwidth, multiple language, not for the condition of the conference then.
Ending this conversation on these words is beautiful because they're almost the thesis of this whole series and conversation, which is that not until AI is grounded in the human realities will it become something that, in quoting what you mentioned previously, strengthens systems, builds trust, and delivers actually tangible impact. Abbas, thank you so much. What stays with me from this conversation and from all the interaction I've had over the years with your amazing team at D3 is really these years of relationship building and trust underneath the technology and you putting people at the center of everything you do. And I think this is a reminder that the ground truth isn't just a constraint on the technology, is the reason that we are building that technology. So I think this is very important. So thanks for watching this episode. Don't forget to subscribe if you want to have updates on the upcoming ones, and see you next month.